So this is Theatre 2 in Raigmore Hospital. I've attached some coloured arrows and some dummy surgeons. Let's look at water, the red arrow. 22 litres of hot water are used for every surgical scrub, and each operation probably has 4 to 6 people scrubbing. As an alternative, we could use rubbing with alcohol gel. It is as effective for antimicrobial protection and for surgical sterility as scrubbing. So perhaps we don't need scrub sinks at all. The blue arrow refers to correct waste segregation. This is not only a legal requirement and a cash-saving exercise, but it is one of the best recruiting sergeants in theatres for environmental actions. Most people hate waste and want to do something about it. The purple arrow refers to some pilot work already being done to quantify the benefits of reusable textiles, both gowns and drapes, and the steps we need to regenerate NHS laundry services. And the green arrow indicates a proposed innovation project we're working with now, looking at real-time monitoring of instruments and their use, and that will help with leaning surgical trays, reducing unnecessary opening of supplementals, and of course unnecessary sterilisation of unused instruments. On the next slide, there are 3 green arrows. These are about energy use primarily. These things are about things we leave on 24 hours a day, 7 days a week, every week of the year. So theatre ventilation and anaesthetic gas scavenging pumps are generally left running every day in Scottish theatres, and we need an automated, motion-activated system to reduce energy use by up to 66%. 7-bar surgical air, that's something that's provided 24/7 again, but despite that, it's only used for 4 minutes a day in orthopaedic theatres, and some theatres not at all. So local cylinder provision of 7-bar air could provide the necessary use and allow switching off of these industrial compressors. The yellow arrow, it's to remind us that even with the discontinuation of desflurane in Scotland, we do need to continue with good husbandry of the remaining volatile agents, with minimal fresh gas flows and end target control to minimise their contribution to global warming. And to finish the tour, the yellow arrow represents a few things for the future, and Phil's going to speak about our innovation arm next. But we have a study in progress looking at whether anaesthetic gas scavenging systems are actually necessary, given modern theatre ventilation capabilities. We're actively engaged in assessing volatile capture technology, possibly for destruction, but possibly even for reuse. But first of all, we need to assess the different methods and the providers in order to assess the capture efficiency. Nitrous oxide is a gas now used in only minimal quantities in anaesthetics due to clinical practice change, but it's still a major healthcare polluter from other areas in the hospital. So apart from dealing with the waste of nitrous oxide, we need to look at realistic alternative treatments, both pharmacological and non-pharmacological, in order to minimise the use of this gas, which remember has a 114-year atmospheric lifetime. Once we've done those steps, we can also look at the assessment of the destruction of the molecule. And of course, speaking of practices, anaesthetic rooms are peculiar to the United Kingdom. We all know and acknowledge that anaesthetising patients in theatre has benefits for patient safety, for moving and handling, and there's a cost benefit to stopping duplication of equipment and space. We also know that the most wasteful time for anaesthetic volatile gas emissions is at the start of an anaesthetic. So we do need to question why we continue to prime and use 2 anaesthetic circuits and of course duplicate all our anaesthetic equipment.